Thank you, Jan. Colleagues, yes, in fact, similarly or even more for gastroparesis, we are dealing with challenging conditions here. And I'd like to start by saying that words are important for human beings. They help us to understand each other. What about the word gastroparesis? The word gastroparesis basically means incomplete paralysis of the stomach. And this is one issue that may drive attention by doctors and specialists in particular. The current definition in the scientific literature slightly modified this simple definition by adding symptoms to the partial paresis of the stomach. Therefore, the current definition in the literature is not only paresis of the stomach, but also symptomatic paresis of the stomach. And the symptoms that were originally linked to the paresis of the stomach were postprandial fullness, early satiety, nausea, vomiting, and bloating, probably upper abdominal bloating. Interestingly, the concept of gastroparesis is losing interest along the way, and investigators focus their interest on symptoms more than on the paresis of the stomach, and they define the severity of gastroparesis not on delay or gastric emptying, but rather on the severity of symptoms. With mild gastroparesis, they are able of maintaining a regular diet with symptoms that are easily controlled. Compensated gastroparesis, they have to change their dietary habits, and doctors have problems in controlling the symptoms. With gastric failure is, again, no mention of delayed gastric emptying, but again, severity of clinical conditions, which is probably what really matters to patients. And later, also symptoms in the literature change, and surprisingly, at least to me, diffuse abdominal pain or non-specified abdominal pain was added to the list of symptoms of gastroparesis, which to me is more suggestive of lower GI conditions. Therefore, again, looking at the literature is not that easy altogether, but taking this into consideration, what we all agree is that gastroparesis is generally asymptomatic in over 1/3 of the cases. It can be diabetic in 1/4 of the cases, and then there are less frequent conditions associated with delayed gastric emptying, and also an idiopathic or post-infectious gastroparesis has been reported, similarly to what described for dyspepsia and IBS. Given this definition, there is a major overlap between dyspepsia and gastroparesis. And if we don't consider secondary forms of gastroparesis, idiopathic gastroparesis overlap almost completely with functional dyspepsia. 90% of patients with gastroparesis will end up being classified as affected of functional dyspepsia, and we all know that in functional dyspepsia, approximately 1/3 will present delayed gastric emptying or partial paralysis of the stomach. But if we include also abdominal pain, then things become even more complicated. And enteric dysmotility or even pseudo-obstruction, of which we will hear later on, overlap with these conditions. And we still focus probably too much on the stomach in some of these patients where the condition probably is not localized to the stomach altogether. Together with Jan Tak, we highlighted some of the problems with the concept of gastroparesis that are listed here. Again, despite the name suggestive of a motility problem, the severity is defined by the symptom, similarly, for instance, to dyspepsia. And there is this major overlap with the wrong definition of postprandial distress syndrome and chronic nausea and vomiting syndrome. Measuring techniques used for measuring gastric emptying have limitations to themselves. There is an existing correlation between symptoms and gastric emptying times, but the correlation is not a strong one. And due to this poor correlation, there is this discordant effect of prokinetics on gastric emptying and symptoms. And focusing on gastric emptying, it does not allow us to take into consideration other potential pathophysiological mechanisms. Another important issue to me is that we forget about asymptomatic gastroparesis that may be important, if nothing less, in diabetic patients where symptoms often are blunted. I was alluding to the limitations of current techniques for gastric emptying. All techniques have advantages and disadvantages, and you can see here listed scintigraphy, breath tests, high-calorie test meals, low-calorie test meals. And if we look at scintigraphy, it's the only internationally validated technique and therefore represents the gold standard. But it's available only in a few centers. It is invasive, expensive, and therefore it's impossible to use in large trials. Breath test is much cheaper, is non-invasive, therefore suitable for repeated studies in the same patient, but has never been internationally validated. High-calorie test meals are more sensitive in mild forms to detect the intermediate forms of gastroparesis, but severe patients will not be able to eat large meals, therefore cannot be used for the severe cases, while low-calorie can be eaten by all patients, but the sensitivity is lower and is borderline to be able to modify fasting into postprandial motility altogether. And the threshold for these had been calculated several years ago, being around 250 calories. And you know that there is a close correlation between calories and emptying time. And if you look at the tests that are available, the liver scintigraphic tests was around above 600 calories, a large, or let's say it's not a large meal, it's a regular meal that we all eat. While all the other tests, breath tests with egg or spirulina, are below 250, and the egg test with scintigraphy just above that limit. Therefore, for different reasons, gastric emptying tests are not perfect measurements for the patients. The correlation with symptoms has been a matter of discussion for a long time. This is a recent publication by the Gastric Consortium, and they do demonstrate with the scintigraphic tests there is a correlation. You can see here that the severity of symptoms is is significantly present only with a severe delay of gastric emptying and not in the mild forms of delay of gastric emptying. And these data basically replicate or confirm data that we published, unfortunately, many years ago. And we are replicated later by many other groups, both in the idiopathic forms and in the diabetic gastroparesis, as long as a sufficient number of individuals were included in the studies. Therefore, yes, there is some correlation. We try to go the other way around and describe severity of gastroparesis not on the basis of symptoms, but on the basis of the severity of delay of gastric emptying. And we defined extremely severe delay of gastric emptying when it was above 3 standard deviation above the mean, compared to traditional delay of gastric emptying of being above 2 standard deviation above the mean. And in fact, it seems to identify a different group of severity of gastroparesis with more severe fullness and nausea compared to normal gastric emptying. But our approach, that is again an old one, nowadays is no longer followed by the literature. What are the mechanisms, the subtle mechanisms underlying these conditions? And the group who's working primarily in this field is the group at the Mayo Clinic collecting samples from the Gastric Consortium. And I apologize for summarizing in a very crude way a number of very elegant studies that have carried out by this group, and I try to summarize for you in this way. What they say that they can identify macrophages in the enteric nervous system, basically in the wall of the stomach of these patients, and activated the macrophages in their hands, produce pro-inflammatory mediators like interleukin-6, you can see here TNF-alpha, and so on and so forth. And these type of macrophages, or M1 macrophages, would derive from circulating monocytes, as opposed to resident macrophages, or M2 type of anti-inflammatory cells, producing interleukin-10 and HO1. If you move to the gastroparesis setting, they observed, compared to controls, an increase of activated macrophages, a decrease of resident macrophages, which obviously are pro-inflammatory mechanisms that would affect the interstitial cells of Cajal, and therefore the myoelectrical control of gastric motor functions. This is a summary of a large number of studies, actually, and interestingly, basically the same results are obtained in other myoelectrical functions, such as in the heart. And in this elegant review recently published in the New England Journal of Medicine, they observe that there is a disconnection of macrophages from cardiomyocytes in patients with myoelectrical abnormalities, to the point that this review ends by saying that targeting macrophage modulation of cardiac conduction may be more effective means by which to tackle arrhythmias rather than targeting cardiomyocytes themselves. Basically, what the Mayo Group and the cardiologists say is that the macrophages play a major role in controlling the production of the signals, the electrical signals that regulates myoelectrical activities. One of the limitations of this research is that it's focused exclusively on the stomach. And you can go through the literature, no matter what kind of paper you select, you will end up exclusively with gastric biopsies. And this is, in my opinion, a major limitation of this study, particularly because, as you all know, words can be misleading, and sometimes they are difficult to interpret. And gastroparesis is not an exception in this regard. Is gastroparesis truly a gastric problem? Is it truly a problem of delayed gastric emptying? Well, we all know that symptoms of gastroparesis can be certainly partially associated with delayed gastric emptying, but also with impaired funding accommodation, over-distended antrum, hypertonic pylorus, loss of antroduodenal coordination, abnormal small bowel motility, gastro and particularly intestinal, chemical and mechanical hypersensitivity, and so on and so forth. This is an old example that was later confirmed in several studies. On the left-hand side, response of a normal stomach to ingestion of the meal. You see a nice distension of the gastric fundus and an active antrum emptying basically homogenized or liquefied solids into the duodenum. And the other way around, in a symptomatic subject, you can see that the fundus is unable to distend, and therefore all the ingested food empty rapidly or moves rapidly into an over-distended antrum, which is probably not as efficient in grinding the digestible solids into homogenized meal to be emptied safely into the duodenum. And this is not taken into account in the terms of gastroparesis. We try to look at this idea of a more diffuse motor disorders in almost 90 patients with moderate to severe symptoms of gastroparesis, typical symptoms of gastroparesis, and we performed a breath test on these patients, and we found, again, approximately one-third, approximately 30%, slightly less than 30%, probably because of the low-calorie content of our test meal, of delayed gastric emptying, which is fine. But in the same group, we performed also small bowel manometry, and look at this. 80% of these patients had small bowel motor, recognizable small bowel motor abnormalities. Therefore, is gastroparesis a gastric problem? I don't know. It's probably a very diffuse problem, motor disorder, and we are looking just at a tiny aspect of its pathophysiology, directing therapies, remember this, and directing drug companies probably not necessarily in the right direction. For instance, this is another example of other investigators who describe esophageal dysmotility is more common than gastroparesis in diabetes mellitus. Again, words are important, and probably gastroparesis is distracting investigators and driving attention, not necessarily in the right direction. Let's move to clinical management. Basically, this is what is generally written in the literature. We have to rule out reversible causes, including potential exacerbating medications, achieving tighter glucose control in diabetics, implementing dietary and lifestyle changes, improving gastric emptying, alleviating associated digestive symptoms, plus other suggestions, decrease acid production, improving gastric accommodation, and so on and so forth. Basically, the only data that have been tested in scientific studies are improving gastric emptying and alleviated associated digestive symptoms. And no wonder, therefore, that the white paper of the AGA published again recently on clinical gastroenterology and hepatology reviewed the literature as saying that there is a strong recommendation for using prokinetics in this group, although the level of evidence is low. And all the different prokinetics that they took into consideration, which is just a tiny fraction of the prokinetics that are available, were not supported by strong recommendation, or at least the only strong recommendation was for erythromycin, but the level of evidence was moderate. Interestingly, they suggested that botulin toxin was a strong recommendation not to use with a high level of evidence as opposed to gastric electrical stimulation, which was uncertain. Let's take a look at a few of these data. I don't have the time to go into discussing the prokinetics. They all have some limitations. The studies that were carried out are old-fashioned and not acceptable for current standards. That many of them are characterized by tachyphylaxis on the long run. Some of them have side effects, including severe side effects on the central nervous system, on the heart, on cardiac arrhythmias, and so on. Many available drugs are not available in all countries, and therefore difficult to compare in different conditions, and some of them induce an unphysiological gastric emptying acceleration, and so on and so forth. I will discuss just a few issues here. Again, we don't need to accelerate gastric emptying too much. I will tackle shortly about the new possible therapies, and something that is very interesting to me is combination therapies, and just a few words on pacing of the stomach. This is an example showing that is not necessarily, or we should not accelerate the gastric emptying too much. The strongest drugs for accelerating gastric emptying are motining-like, like erythromycin. This was developed, ABT-229 was developed by Abbott, and interestingly showed that it's accelerated very efficiently gastric emptying, although unphysiologically, because they mimic phase 3 activity of the migrating motor complex. Therefore, even undigested solids will enter the duodenum, but the improvement of symptoms was stronger in placebo as compared to the active, because the active drug induced symptoms because of this unphysiological emptying of the stomach. Our chairman today, Jan Tak, made this meta-analysis of all studies with different prokinetic agents investigating gastric emptying, effect on gastric emptying and on symptoms, and found no correlation between these two phenomena. And the main conclusion is that no rationale in retesting gastric emptying after treatment is initiated. If you want to investigate gastroparesis, you need to have a gastric emptying at the beginning, but afterwards what you are interested in is the improvement of symptoms. Basically, this is the message of this study. New data, this has just appeared on gastroenterology. Again, Jan Tak was involved. First name is Michael Camilleri. They investigated the effect of the ghrelin-agonist relamorelin in almost 400 patients. You can see here on the left the effect of different doses of the ghrelin agonist on bloating, nausea, fullness, and abdominal pain compared to the black line, which is placebo. And here on the right hand side, overall symptoms, and symptoms improved significantly with these injectable treatment, despite the fact that on gastric emptying that was only marginal compared to placebo. Again, our chairman is very active in this field, failed to demonstrate an effect of botulin injection, and this is probably the reason why the AGA white paper dropped this the concept of injecting botulin in the pyloric region to accelerate gastric emptying. But the people in Leuven did not give up, and this is interesting to me. They continued to inject botulin in the pyloric area of their patients not responding to other therapies, and they associated botulin injection with pneumatic dilatation of the pylorus, and apparently they reported an improvement in almost 80% of their patients. So this is an example that in real life we must translate the results of clinical trials into our practice. And another example is coming from GPs, and they published an association of metoclopramide and erythromycin. Erythromycin failed in clinical trials, but it encounters severe tachyphylaxis. But these people, these colleagues, what did they do? They combined metoclopramide and erythromycin, decreasing side effects and decreasing tachyphylaxis. Another example of probably what we should do. What about pacing the stomach? In my opinion, is a failure, and obviously American colleagues would disagree with me. The reason why I say so is that of the 11 published trials, only 3 were randomized, despite the fact that it's very easy to randomize in a controlled fashion, because we can turn on and off the device, and therefore I don't understand why they carried out 8 uncontrolled studies with this technique. And of the 3 controlled studies, 2 were completely negative, and only 1 was partially positive, and it showed that to improve only vomiting and only in diabetic gastroparesis. And these are mainly the reason why in my practice I recommend this device only in non-responders diabetic gastroparesis with vomiting. I'm finished, and my first take-home message is that the term gastroparesis, the way it used nowadays, links symptoms to an objective digestive abnormality, which is good because particularly for authorities, finally they have an objective finding to deal with. They don't like symptoms alone, but it focuses attention on gastric abnormalities alone, and basically in the clinical trials it's used as dyspepsia and nausea and vomiting combined together. Delayed gastric emptying and postprandial distress syndrome and nausea and vomiting are only partially related to each other, and other gastric and extragastric pathophysiological mechanisms may be involved. Measuring gastric emptying, the techniques that are available are suboptimal, and probably we would need better techniques in the future. And again, what matters in the vast majority of cases to the patients, they don't care about the gastric emptying times. What they are interested in the ability of finish a normal meal without feeling full for several hours after ingesting of the meals. This is my final slides. Asymptomatic, as I mentioned, gastroparesis may also be relevant, for instance, in postprandial glycemic control in diabetics. Dietary and lifestyle adaptations are necessary in all patients with gastroparesis, although scientific data are not existing to support this attitude that we all adapt in our patients. A number of therapeutic options are available to improve gastric emptying and or associated symptoms, but management of many patients in our hands remains unsatisfactory. And combined therapeutic approaches are likely the way forward in clinical practice, but appropriate studies are unlikely to be carried out to test this hypothesis. Thank you very much.